and also in New Zealand and Australia. Shire is a large region bordering Glasgow, so we're the third most deprived health board in Scotland. And North Lanarkshire is one of the poorest areas in Scotland that has been experiencing health loss following years of austerity. So Scotland is amongst the poorest health in Europe. We have a high level of drug deaths and larger health inequalities than the rest of the UK. So with the Bread and Roses title, these are analogies for basic securities, including nutritious food, adequate and warm housing, along with the roses of life that bring life meaning and value. So it was a slogan used in campaigns for struggles for fair wages and dignity at work. And I use this title as I think sometimes we might overlook some of the basic needs in the populations that we both serve and extrapolate research findings to. So just to acknowledge input from my supervisors, Chris, Emmanuel and David, and my co-authors in research is Claire, Ruth, Clemmy and Jackie. So between us, we have backgrounds in physiotherapy, sociology, medicine, social science, and Ruth also lives with chronic pain. So just to acknowledge funding for my PhD studentship from NHS Lanarkshire and Glasgow Caledonian University. So this is paid to me through my wages with NHS Lanarkshire, and that I am a white Scottish middle class, non-disabled cisgender woman. So I'm going to put across the following arguments in my talk and ask the following questions. How can services better reflect long-term and non-linear needs for all? And in what ways can we consider pain as political? So I'm not going to read these all out just now, but we'll return to them at the end, where I'm sure there will be plenty to discuss. So just an overview of my talk. I'm going to give a bit of an understanding of ways of an overview of kind of understanding health inequalities. And then I'll talk a little bit about the meta-ethnography and then a couple of studies based on that, and then cover a little on approaches to care that I think can be considered systemic responses to inequities. And then we'll hopefully have about 15 or 20 minutes for questions and discussion at the end. So definitions in the UK might use inequalities and inequities interchangeably, and apologies in advance because I do this. So health inequalities are defined by Health Scotland as the unjust and avoidable differences in people's health across the population and between specific population groups. So these are socially determined by circumstances largely beyond an individual's control, and these circumstances disadvantage people and limit their chance to live longer, healthier lives. So this definition already brings in ideas of justice and equity. So just to be clear, we're not talking about genetic determinants or differences between groups of people without the equity issue. So some of the broader work that's done around the social or micro to macro framing, some of this does and some of it doesn't take in an equity framing. So all of these things are important for the individual, but I'm just going over inequalities here. So I think that a helpful way of thinking about inequalities is to think about upstream causes flowing to downstream effects. So you might be more familiar with the effects, situations, and behaviours of your individual patients. So you could consider things like capacity and behaviours around eating, exercising, substance misuse, patterns of engagement with healthcare, and how these factors are associated with health outcomes, but then looking to the upstream causes. So these are the powerful and modifiable determinants of health. So these include policies affecting things like access to housing, education, healthcare, social security, and also industrial policy and workplace regulations. So I think ideology and cultural narratives are important to factor in, such as language and ideas promoted by politicians and media that have dehumanizing effects and create stigmatizing attitudes, leading to marginalization of groups of people, such as disabled people, refugees, and many of our patients. So if you track back up as well, inequalities in power, wealth, and income are recognized as the fundamental causes of health inequalities. So hopefully that covers some points around the ways in which we may consider pain as political. So a common way of looking at, sorry, just lose my bit of paper. So a common way to give data on health and pain inequalities in the UK is area level socioeconomic data using the index of multiple deprivation. So this data here in the numbers is showing the prevalence of chronic pain in adults. So it's given in England in quintiles. So this is an index, and the most deprived fifth has 41% prevalence of chronic pain, and the least deprived fifth has 30% prevalence of pain. However, if you look at the Scottish data, it's given in deciles, so these are tenths of the index. So the most deprived decile has 50% prevalence of chronic pain, and the least deprived 29%. So deciles are likely important to better understand health loss in poorest communities, because the health of the most deprived 15% of the Scottish index of multiple deprivation is becoming more detached from the rest of the population. So drivers of persistent health inequalities include lack of improvement in living standards, the impact of austerity on public services and poorer communities bearing the brunt of austerity, and severe forms of multiple disadvantage presenting greater risks of higher mortality and include homelessness, opioid dependence, imprisonment and psychosis. So the graph here is from the Torrance reference below, and it shows strong opioid prescribing across quintiles in Scotland from about a decade ago. So this goes way beyond the inequalities in the prevalence of chronic pain, and even accounting for increased severity in more deprived areas, there's still a noticeable difference. So there's multiple factors going on here, and a concern here is that people may receive medication prescription over time in consultations and quality interdisciplinary care. So this is also where the inverse care law comes in, which says that the provision of services doesn't match the higher need in areas of deprivation. So a more common way to look at socioeconomic status in the pain literature is through individual socioeconomic status. So this commonly includes education, income, employment status, or social benefits. And a recent systematic review found that all of those except employment status showed an association with chronic pain. So you might wish to add in financial security and also social status or class. So the graph that I'm showing you here were responses to a poverty screening question that we introduced in that interface service in Lanarkshire. So this was in response to the cost of living crisis. So we asked people, do you ever have difficulty making ends meet at the end of the month? And as you can see, over half of people have responded that they always, frequently, or sometimes have difficulty making ends meet at the end of the month. So if you don't do poverty screening and you do want to do it, I would suggest working with your public health or health improvement teams on that. So just moving to another intersection. So this is the work of Anna Hood and colleagues that brings racism exposure into a trauma model. So it's very relevant to the United Kingdom, with a recent English study showing 10% higher prevalence of chronic pain in Black people over any other ethnic group. So the conceptual model here goes from the micro to the macro and illustrates the context of structures, including cultural and institutional racism. Importantly, it points to the need for structural and institutional changes to achieve chronic pain equity and suggests that a focus on individual processes alone maintains inequities. So if you're interested in the broader literature on anti-racism, I would suggest Rennie Edo-Lodge's book, Why I'm No Longer Talking to White People About Race. So it's very readable and for a UK audience. So it's important to consider the multiple and fluid nature of inequalities and that they are intersectional. So there are lots of models of the intersections. The main thing about this model is that the important bits are around the outside, and inequalities are maintained in systems of power and oppression. And the point is that this can change. So our political systems do not fall on us from the sky. We create them together, and each of us may have different roles to play. So that was a brief overview of some ways of thinking about inequalities concepts, and I'm just going to pick back up on some of that towards the end of the talk. So, well done to anybody who managed to read the paper. It's quite a lengthy piece of work. And I have to say, like, it's very tough to even get it down to the word count that it's at, which is 9,000 words. So it's a very lengthy methodology, then obviously there's the findings to publish as well. So I'm very grateful to Flick and Roger at the British Journal of Pain for giving us the space to publish it, or whoever was involved in those decisions. So why study acceptance of chronic pain? Is something that I have been asking myself quite a lot recently. So we just talked about how pain is highly prevalent and inequalities reflect social inequalities. And obviously, acceptance of any of that is unhelpful. However, for individuals, including my patients with severe long-term pain, often there is simply not a cure. And for a variety of reasons, they might end up taking too many drugs that don't work, can make things worse, or pursuing unrealistic answers based on beliefs associated with an outdated medical model. So often people can fall into an unhelpful cycle of disability distress with the onset of multiple long-term conditions. So acceptance is often recognised as a useful shift in approach to management associated with improved mood, quality of life and healthy behaviours. And there is obviously a level of judgment that you and your patient may make about when it is helpful to accept what. So nuance is needed. So in this way, acceptance can be recognised as a behaviour or approach of the individual with pain. And it was with this in mind that I approached my PhD many, many years ago. So if you think about it though, prescribing is a behaviour of the clinician, and we're all continually coming into contact with the cultural biomedical model. So researching chronic pain is obviously challenging because of the heterogeneity across the conditions, severity, sort of impact, and also biopsychosocial domains. So acceptance is often conveyed as a particular psychological construct within the psychological flexibility paradigm. However, the qualitative literature shows a contested and complex set of phenomena that are relational to each other and many different factors. So we took the theoretical position of acceptance of chronic pain being socially constructed. And with the meta-ethnography, we aimed to conceptualize the lived experiences of acceptance of chronic pain in adults. So, meta-ethnography is a literature synthesis method that starts with a systematic search and then it becomes increasingly more interpretive throughout the synthesis phases. So important to note here that chronic pain was the primary condition. So we didn't include studies where the chronic pain was a sort of secondary condition, such as to cancer or HIV. So after the search and purposive sampling, we included 10 studies. And in meta-ethnography, you can analyse the thematic findings that you get in relation to the study context, including sort of recruitment and also participant demographics. And we found that education level was the most common proxy for socioeconomic status. So this is the conceptual framework of our findings, which is titled An Ecosystem of Accepting Life with Chronic Pain. It is represented by a rose bush containing both roses and thorns, such is the nature of accepting life with chronic pain. So around the outside are the socio-cultural political aspects of the ecosystem, including the roots. And in the centre are the different ways that acceptance is conceptualised within the studies as a fluctuating state. And this includes as resignation, as failure, an equivocal or automatic state, or a desirable state that is worked towards without a definite endpoint. So around that, there is the fluid and continuous journey, which is ongoing, fluctuating, evolving, occurs on multiple levels, and is likened to learning, growth, and grieving. And there is a tension between acceptance as a state and accepting as a process. So I'm just going to show you some aspects of the findings in closer detail. So the phrase turning point often appeared in the studies, and it represented a feature of the journey that represented a shift in attitude and approach to living with pain. It was associated with adaptation and accepting life with chronic pain. And there was a sort of spectrum of it being a more immediate, noticeable thing to a sort of gradual, multiple thing. And it could occur in life and in healthcare. So experiencing dawn was one example, representing a significant event of insight, understanding, or clarity, a stepping out of darkness. But then on the other side of the spectrum, it wasn't a sudden kind of thing that one morning I woke up and said, well, I accept this and that's that. It sort of gradually came about. And I think that that process is probably ongoing. It's not a sort of final thing. So there are aspects to the individual journey that are described like steps or sometimes strategies. So we found that these could include having a diagnosis or name for the symptoms, recognition and acknowledgement of no cure, letting go of pursuit of a cure, redirecting effort from controlling the causes of pain to managing the consequences of pain and adaptation, acknowledgement of limitations and of no return to normal pre-pain life, and creation of space to look forwards. So I'm just going to let you read the rest of them yourselves while I have a drink. I genuinely scheduled that in. And the final one there is grieving losses. So this is not an exhaustive list and it's not in order. So bear in mind the fluctuation and fluidity that occurs. So you might recognize some of these from your own clinical practice, but also bear in mind that different services may play different roles along the journey. So for example, the issue of diagnosis or name for the symptoms may be more key to primary care or to physios, but by the time a psychologist sees someone, aspects of this sense making may have become counterproductive and unhelpful. So the iterative steps and ongoing nature reflects the idea of condition management work that occurs with chronic illness. You might also see some of these as therapeutic targets, and you might observe that some of these are potential sources of inequity, such as the creation of space. So poverty is well known to bring more burden and chaotic lives. So I'm going to talk about outer aspects of the ecosystem now. So language and meaning of acceptance and the painful condition. So many studies actually started with a theme on the difficulties with the language of acceptance. And the issues with language and meaning are partly related to the fluidity of the phenomena. So we find that they're both individually and socially constructed, related to conceptualization of health, illness, pain, and capability. They're difficult to articulate, invite contradiction, and appear to be a contested concept. So acceptance could mean failure or resignation, but for others, it's something more desirable. So the word acceptance could provoke resistance, as I'm sure anybody that works in clinical practice would know. I certainly never bring it up with anybody initially. But it's also pivotal to moving forwards. So this is a really important concept. So preferred terminology could include coming to terms. Accepting as a verb might be more appropriate, as the term is usually referring to an ongoing process. So language and meaning of the painful condition. So the studies show that having a name for the symptoms or diagnosis, if you want to sort of understand it that way, and the meaning attributed to this could provide validity and insight to the person with pain. This diagnosis should be associated with a management plan. So a more accepting conceptualization could be associated with the pain being viewed as non-threatening, recognition of the long-term nature of pain as similar to any other chronic illness. So the meaning of acceptance was also related to the meaning of the painful condition. And so this is all obviously a tricky topic. I think fibromyalgia is possibly a good example of the variety of meanings for the same term. So it can be unhelpful for some and helpful for others. So just to remind you, in our meta-ethnography, we included people with chronic pain as the primary condition. So this is a group of people who, from a clinical experience, have a pretty tricky time navigating healthcare. So the caring, supportive and coherent system is represented by the roots, and it includes healthcare, workplaces, the political environments and cultural norms. So supportive and caring communication is clear, open and empathetic, and it helps one to feel believed and validated. Just a couple of examples here that I'll read out. Looking back, I think I needed somebody to sit down and talk with me and say, yes, your pain is real, and let's talk about what we can do to help you learn to accept to live with your pain. Another, the importance of having a GP who is willing to learn about CRPS and to whom you could talk without feeling like a burden was of prime importance. So unclear and uncaring communication could lead to emptiness, vulnerability, and feeling abandoned. And a breakdown in trust with healthcare professionals can be brought on by lack of acknowledgement of pain, feeling not listened to or dismissed, and not taken seriously. So it helps if healthcare staff acknowledge the uncertainty and unpredictability of pain, and at the same time validate the pain. So support can be practical or emotional, and sharing, particularly with others who have pain, helps to normalize the condition like any other chronic illness. So the quote here illustrates the role of finances. So the person would rather pay someone for services such as house cleaning. So I'd rather fork out $40 and be able to go to work tomorrow than do it myself and not be able to go to work. So with coherence, the painful condition ideally needs to make sense to the person with pain, which may be a challenge with a condition like chronic pain, which one could argue is incoherent in nature. But importantly, systems and culture also need to provide a coherent experience in fitting with the nature of chronic pain, the limitations it can bring, and the necessary adaptations. So we found a challenge to identity that we related to a struggle to live up to the ideals of a capitalist society that requires achievement and ability of its citizens. So acceptance of chronic pain and its consequences may be viewed as personal failure, surrender, or giving in if one identifies as an active, capable person and cannot accept the limits that pain brings. So reconciliation to a new or changed identity was helpful to accept chronic pain, but not everybody could do this. So we're thinking about structures and the impact of ideology on our patients, and in this case, the participants in these studies. So Brady and colleagues, this study was in Australia, and they conducted their study with 3 different groups of first-generation immigrants. So with their Vietnamese group, they found that rather than an individualistic point of view, Vietnamese integrated their sense of self through their relationships with others and their community status. So this is a quote that I relate to from clinical practice quite a lot. So perhaps the most significant barrier to the women's acceptance was the struggle to maintain their pre-pain identity. So they often used their limited physical, mental, and emotional energy to maintain an appearance of normalcy. The result was that their health status and quality of life further declined, often until they hit a crisis point that forced them to reevaluate. So ultimately, acceptance of chronic pain was inescapably tied to acceptance of a changed identity. So in the meta-ethnography, we've sought a new interpretation of how cultural norms of ability, achievement, and personal responsibility are promoted and maintained in our Eurocentric culture, which of course the person with pain and their healthcare professionals continue to interact with. So this is the final slide for the meta-ethnography, and this is the most interpretive finding. So a strength of qualitative research lies in inductively generating new perspectives and insights on complex issues. So we used meta-ethnography to generate lines of argument across studies based on both what was said and unsaid in the study themes relative to the study context. So we use study context and not just quality appraisal in the interpretation. So we found that the 2 study populations with the highest education levels more frequently described an accepting perspective, whereas the 2 study populations with the lowest education levels were more often conceptualized acceptance as a state of resignation or failure. So the studies did not report demographics consistently, so we could not make further comparisons of the socioeconomic context. Nevertheless, these findings suggest that socioeconomic factors could have a bearing on the extent to which people are accepting of life with chronic pain. So some study participants have been able to move forwards in the accepting process with insight, reevaluating identity, and reach out for support, particularly so in the studies where participants had completed a pain management program or had higher education levels in the demographics. So this could suggest that rather than focus solely on individual agency, enhancing accessibility to care and support could have a positive impact on individual lives. So the ecosystem has been a useful discussion and reflection tool. And now that I'm at the end of my PhD, I've conducted two separate engagement studies. Both of those had aims to find out how different groups of people related to the meta-ethnography findings, thus contextualise them and to generate ideas for how the situations could be improved. So one was with 25 interdisciplinary staff at Fife Pain Management Service, and the other was more in depth with people who live with chronic pain in Lanarkshire. So these have led to different versions of the ecosystem. So the intersectionality piece was really the theoretical background to this study. So we recruited 7 Lanarkshire residents who live with chronic pain, and the term that I used that I probably wouldn't use again is adverse experience of health inequalities. So in developing the methodology, I used 2 lived experience advisors. I tried to be inclusive as possible, which really necessitated NHS ethics approval for the recruitment. So I conducted individual interviews for the demographics, and this was some at home, some using the telephone, and some using video call, depending on their preference. And then we conducted focus groups and diaries to gather the qualitative data. So I was quite struck by the severity of the impact of the pain on these people's lives, both from the demographics and from the qualitative data. They all had multiple long-term conditions, fairly low education levels. I don't think that any of them were in paid work. So this is just preliminary. So I think the only certain thing here is that this will change. So you can see a barrier theme here, which is the thorns will be around that. So the dehumanizing, incoherent and unaccepting systems. So this was directed at both social security and aspects of the health service. And then there was a sort of roses theme, if you like, which was understanding and accepting systems and the qualities of that. And then there was individual variations in the experience and journey. So that's what I am working on just now. So we also used the World Cafe method to conduct a study with NHS Fife Interdisciplinary Pain Management Service. Hello to anybody from Fife who's here today. So we used 25 staff. So this included 4 physios, 4 pharmacists, 4 psychologists, 4 medics, and OT nurses, and also administrative and support workers. So the World Cafe method emphasises the cafe environment, so we attended to a lot of detail with coffee and cakes and ways of cross-pollinating ideas. We had 4 cafe rounds with small table moderators and gathered qualitative data from post-it notes on a wall summary, not that one, table notes, and then also moderators' notes as well and reflections. So I did have a secondary aim of testing out the World Cafe as a research method as well. So just in terms of the thematic findings, staff valued the capacity of the ecosystem to convey the complexity of the concepts that they were used to working with. And we discussed concepts that they thought should feature in any conceptualizing of accepting chronic pain. So I'll show you a new rosebush in a moment. So staff described the dominance of the biomedical model as a barrier to accepting, and there was also recognition that socioeconomic factors and disadvantage played a role in their patients' experiences with chronic pain, but they were less sure of how and what their role and the role of the service was in managing that. So hearteningly, they found that their role was to provide the roots of the ecosystem. So I ended up having to redo the ecosystem, which is a terrible, terrible thing. Obviously hated that. So you can see the qualities that they valued and that they considered that any improvements to their service should reflect. So you can see features of education being important, and this was for staff, patients, communities, the multidisciplinary nature, access, consistency, trust, and also fitting around the long-term needs of patients as well. So what you'll also see is that there are earthworms in the soil. So this represents the nutrition of the soil. So the roots themselves require sustenance. So that's the caring and supportive and coherent system for you guys. So the fluctuating states in the centre of the ecosystem include the most relevant acceptance states. And now, additionally, they include fluctuating states of emotions, feelings, and knowledge. So these now include shame, worth, understanding, uncertainty, and pain itself as a fluctuating state. So the middle layer includes features of the ongoing journey and also processes or potentially mediators, as suggested by either the meta-ethnography or the World Cafe findings. So this now includes stigmatization. So I put this in over stigma to draw attention to the active process that takes place within our society. Also includes trauma and validation, and I've adapted the social, cultural, and political aspects of the outer layer of the ecosystem. So I've positioned accepting as an overarching concept that takes place within an ecosystem. However, the more commonly understood idea of acceptance in the pain literature is still visible within the ecosystem. So just to say as well, you can, if you want to, you can use the previous figures from my work under the Creative Commons license if you accompany it with the correct citation, but you can't share this one because it's not published yet. So just to finish, I just wanted to relate further models that take concepts that are relevant to chronic pain, both as an individual factor and a systemic approach. And I think that they may be beneficial to mitigating inequities. So I thought the literature on health literacy and trauma-informed approaches were particularly relevant to the Fife findings, and so I thought they might be relevant and of interest to staff from other pain services, such as yours. So I think health literacy as a systems approach has a lot of value with a condition like chronic pain. And also given its potential as a mechanism of inequity. So lower individual health literacy and chronic pain is associated with multi-morbidity, lower education level, older age, being unemployed, lower income, poorer disease-related knowledge, and holding unhelpful beliefs about pain. So it is also seen as foundational to healthy behaviour change, reducing health anxiety, and implementing chronic disease management. So it's a concept that is understood as an individual factor, but also principles that are applied to health systems and community knowledge formed across generations. So like anyone can experience pain, anyone can experience trauma, but the impact of it can be exacerbated by structural inequalities. So we know that adverse childhood experiences make the onset of chronic pain and multimorbidity more likely in adulthood. Chronic pain, multiple long-term conditions, and mental health conditions are all socially patterned and more common with poverty. So just looking over to the tree, so different tree metaphor alert here. So trauma, including adverse childhood experiences, can lead to difficulty regulating stress and emotions, and difficulty in managing relationships and establishing trust, which can impact on engagement with healthcare. So just thinking about it, do all your patients attend, participate in, and benefit from your services? So I think that we can consider the link between trauma, pain, and poor health as a mechanism of inequity, and trauma-informed approaches as a service or possible societal level response to inequity. So trauma-informed approaches are promoted by the NHS and by the Scottish Government, and they are systems-wide, from leadership through administrative practices to clinical engagement. They can range from trauma aware to trauma specialists, and they involve people with lived experience in the design and evaluation. They emphasise principles of power sharing, collaboration, shared decision making, and connections. And the SAM HSA document seems to be foundational from my reading on the topic. So it explains sort of what is meant by the concept. There's training for staff through NHS Education Scotland as well. So on my trawling through the literature, I found a systematic review that covered primary and community health services that had adopted a trauma-informed approach, and found the only one that I found anyway that included chronic pain measures was the EQUIP study. So this was in 4 primary care sites in Canada. So they implemented trauma and violence-informed care, contextually tailored care, and cultural safety. So I've noted a publication there, but there's quite a few around that. So, going back to the take-home messages and questions, pain inequalities are socially patterned, so they reflect social inequalities. And the process of coming to terms with long-term pain for the individual is a fluid and continuous journey that takes place within our social, cultural, and political worlds. So we can conceptualize these complex processes as an ecosystem. Inequities and experiences of marginalisation influence the individual journey, including capacity to access and engage with healthcare and condition management. And I wonder if systemic responses may yield greater potential for equitable improvement over focus on individual interventions or factors. And just returning to the questions as well, how can services better reflect long-term and non-linear needs for all? And in what ways can we consider pain as political? And if we do consider pain as political, what implications does that have for us? So there we go. Time for questions.
Brilliant. Thank you very much, Cass. I think but there's a virtual round of applause happening online as we speak. So so I'll tell you what, there there are a few questions in the chat box, and possibly as we get going, people will pitch in as well. I mean, one that's down there is this is obviously not the first field to look at inequity and inequality. There are other big literatures out there, and I suppose I'm particularly thoughtful about the literature in mental health. And can the field of pain learn anything from those literatures? Because this isn't the first rodeo in a sense. And does it make sense to just look at pain cold, or does it help to learn from those other areas?
Yeah, so I guess you can learn a lot from mental health, as that's no doubt about that being socially patterned. I think public health and social science and sociology also have a lot to provide us with. I think one of the keys to my work has been working across disciplines. And so I think I've benefited quite a lot from social science and sociology. And David has a background in public health as well. So yeah, I think mental health definitely, but also public health. That resource that I mentioned, actually, where the definition of health inequalities came from healthscotland.scot, is a great public health resource. So that's good for sort of anybody wanting to sort of know where they can get started with understanding stuff, and covering like what you can do for your service, and also implications for research I would take from that as well.
Great, thank you. Robin's just pitched in with a question. As you've got a greater level of deprivation in Lanarkshire, how's the proportion of health funding on pain management? Has it increased related to the need and larger cohort in your area?
No.
No.
No. Unfortunately not. I mean, there's different approaches to pain management, obviously, and where pain care is delivered, and what the needs of people are. So we have the Scottish service model in Scotland for chronic pain, which does mean that we should have a multidisciplinary team in secondary care that sees patients and that provides some support to primary care. But different services have quite different staffing capacities. And yeah, that it doesn't necessarily follow the lines of where deprivation is greatest, where the needs are greatest.
Hmm. So, so thinking of that index of multiple deprivation, the opioid graph right at the beginning was
Mm.
startling,
Mm-hmm.
really startling about how that changes across the quintiles that you showed there. Are you aware of anybody exploring what the heck's going on or looking at practitioner factors? I'm remembering that the mental health literature shows that, for example, if you're black, you're more likely to get medication and less likely to get therapy. Do we think
Right.
there are similar processes going on there?
There's quite a lot of people in Scotland looking at that.
Hmm.
You might be aware as well that we have high drug deaths, which are very, very socially patterned. So, a lot of them from deciles 1 and 2, sort of the most deprived deciles. So, yeah, there is. I was at the Society of Social Medicine and Public Health conference. There was a 3-day conference last week in Glasgow, and so there was some, yeah, really good work being done on drug deaths to kind of understand it. So things like stigmatizing attitudes of staff was a factor that they found, as well as people's social situation as well. Um,
So
yeah, I
does
mean,
that mean
obviously
I'm going,
it's really complex.
I don't take you seriously, so I'm going to give you opioids? Is that the thought?
I think it's maybe more dismissing certain groups of people in a sort of intersectional way,
Got it.
and sort of access to public life. Perhaps that would be a way of saying
Okay, thank you. So Jen has pitched in with a question, which was about identity and the whole issue of having a prepaying identity and needing to accept a new identity.
it. Mm.
Different spin on this is thinking about people who have developed an extremely strong and disabled identity, uh,
Hmm.
and that this sometimes can impact the rehabilitation. Did you encounter this kind of strong disabled identity as a positive or negative in the research?
No, I don't think that really came up very much in the meta-ethnography findings at all. And I can't say it's something that I really recognise from my clinical practice either. I do recognise it from some of the literature, but not the literature that I included. Um, yeah, there is some interesting work on um, disabled identity and disability and chronic pain, and obviously it's quite a fluid situation. But it's not something that I have personally looked into too much.
Thank you. Yeah, I think the question may a little bit of a Bath-centric question where we see a very
Right.
a very highly disabled subpopulation of the pain population as a whole. So maybe this is too big a question, but are there any do you have a clear model of which aspects of social and political influence inhibit the helpful sense of acceptance?
Um,
I mean, maybe your whole tree answers that, but I'm interested to hear you
yeah,
answer
I
that
was going to
question.
say,
Yeah.
I think that was. So I suppose I think I talked about structures, but also, sort of cultural ideology. So, the idea that we have to be achieving stuff and being productive citizens, or else, we're then sort of marginalized and stigmatized as, benefit scroungers, and the language that's used around about that. So I do think that that's quite powerful, and it certainly seems to be quite powerful in the study that I did in Lanarkshire. So I actually conducted that between March to May. And so it was the sort of final, few months of the previous government. And there was a lot coming out on um, benefits and how people didn't need to be on benefits. And, a lot of those kind of uh, sort of attitudes and language from our politicians. So there was sort of distress around about that, but there was also evidence that people do internalize it as well. And so they use that to kind of beat themselves up and belittle themselves. And um, I don't know if that answers your question. Yeah, I think it is quite, I mean, like some people think that everything should be taken under structures, but I do think thinking about like the narratives and the sort of ideology is also quite helpful to um yeah, for an understanding of possibly like what could change and how things happen and how things impact on our patients as well.
Can
Don't know
you
if
ever
that
use,
answers your question,
okay,
Jeremy.
there's another question coming in from Julia, but I'm going to allow myself a follow-up. Can you use any of that understanding of ideology clinically?
Yeah,
So
uh-huh. Yeah, so I think since I think I quite liked using the idea of identity because it relates um what is going on for the individual person to the cultures. And so like I find it easier now to kind of talk about perhaps a cultural narrative and sort of relate it to my patient, like the idea of sort of working class identity in particular. Um, and to kind of unpick that a little bit with patients. And they can often see that there are sort of cultural expectations and um, ideas like that they've kind of fallen into that they're pursuing. Um, yeah.
yeah, no, that's it's really helpful. I'm just reminded of my work in the field of sexual assault, where understanding issues like
Mm,
victim blaming as a societal ideology was a very important component clinically.
mhm,
Anyway, let's move on to Julia's question, which is the need to address training programs of staff, particularly in the NHS staff, to make sure there's more of a focus on a social model of care. Would you agree
mhm.
with that?
What I don't quite understand, I suppose, what is meant by a social model of care. As in like social care.
Or I don't know, a more yes, I don't know. Julia, can you give us a quick follow-up? I'm sorry if I could find you. You can unmute yourself if you like and pitch in.
Hi, Julia here. I just meant really trying to shift the focus away from the biomedical model, which is so
Mm.
deeply riven
All right.
into the DNA of I work in the NHS, and I've been around for decades, and it really hasn't shifted since I started as a newbie in, gosh, early 80s, really. Does that make sense?
Yeah, do you mean just in relation to pain, or do you mean sort of generally in
Well,
the health
generally, I
service?
suppose pain is just a very good example where the spotlight is
Yeah.
pretty stark. It's just trying to shift, the kind of into a more biopsychosocial way of
Hmm.
looking at people's lives, really.
Hmm. I think so. There's the idea of structural competency. So I actually took the bit on that out of this presentation because it was just too much for 4 o'clock on a Tuesday. But structural competency is about developing a better understanding of structures, inequities, and sort of social determinants of health on like individual factors for our patients. So that's Metzel and Hansen, a 2014 paper. It was actually written for medical education, but I think it's very applicable to all the disciplines. So that I think that kind of education, I think that the trauma-informed care work does that as well. When you start to look at the approaches concept rather than just what the kind of individual can do, but more how the services are sort of structured.
Cool.
It's very difficult. I mean, it's very interesting and it's very difficult with pain, as we move forwards into both interdisciplinary care. So we are kind of hopefully being more equal sort of across the biopsychosocial aspects, but there are the kind of elements of power and power dynamics, and that sort of maintain where we're at. And so it is pushing against something quite powerful. I went back and read the 1977 Engel paper recently, just because that theme had come up in the Fife World Cafe. So yeah, that was really quite refreshing because he was actually talking about sort of the sociology of medicine, and sort of the role of medicine in maintaining power over the individual patient, but also as a sort of what it was like the role of medicine in marketing and advertising and stuff like that. So that was like quite a refreshing read to actually go back to read.
Okay.
That we should maybe revisit.
Okay, thank you. We've got one from Anne Parkinson, which I think is carefully phrased, so I'm going to read it out. Wondering about the compassionate and trauma-informed care being in the roots. I saw some elements of this, but not as a whole. I'm wondering if the different elements of both of these came out in the study at all. A compassionate and trauma-informed workplace ideally needs to be in the soil from all levels of the system, and this is then supportive of staff and people using the service.
Yes.
Yeah.
I agree. So in the meta-ethnography paper, yeah, I think when I was processing this, and obviously you then have to relate it to the literature, I kind of wanted to have a section in the discussion on trauma-informed approaches, but there was just too much to put in there, and so it will be in the Fife paper about that ecosystem as one of the sort of three main topics in the discussion. Yeah, but I think absolutely. I think that you can see that as the caring, supportive, and coherent system, that is so important for us and how we care for our patients. The systematic review that I mentioned, I think it's Natalie Lewis is the lead author. So yeah, that was very much, looking at trauma-informed approaches to healthcare. So that's quite an interesting and heartening. Well, it's heartening in what you're reading, but I think they only got 6 studies or something like that. So there obviously needs to be like a lot more done and sort of data collection done on trauma-informed approaches. But I think that pain services have got potentially a lot to gain from that.
Okay, so we've only got a couple of minutes left, and we've got to draw to a close. So perhaps I can be cheeky and ask you just for your first thoughts towards your own question. What if pain is political, and
Uh-huh.
what does it mean for us?
Um, I think that it involves embracing different roles, I suppose. I mean, we obviously have a role as a citizen, but I think also in terms of the construction of knowledge, as a researcher, so we can make choices around about who we include and who we don't include in our research. We can make choices about, what direction our research goes in. Um, people working in the health service will obviously see individual patients, but also may have a role in service development as well. So I think taking an equity focus in service development as well. So I know that, like you could define politics as the role of the state. But I think it's possible to kind of take a bit of a broader view of the sort of political construction of knowledge. So I think that we are all political, and I think to deny being political is a political statement in itself. If someone says don't be political, it's like, well, that is actually quite a political thing to say. I think the other aspect or sort of consideration that you could have for roles would be as advocates or as activists. So, for example, I don't know if you know Heather Wallace from Pain Concern. So she's got me going along to the Scottish Parliament tomorrow to sit in the health inequalities cross-party group. So there's the role of sort of advocacy and then raising awareness of that work. Yeah, so I think there's different ways, and then of course we make choices outside of our work as well. I think there's a number of ways.
That's brilliant, thank you, and a really good note to close on. So, Cass, thank you for that. It's a great talk. That was quite a lot of useful discussion as well. That was great. So, round of applause,
Thank you.
virtually,
I'll
awkwardly.
go away and think of like 100 better answers to those questions.
No
I'd be
doubt.
like,
No doubt. So yeah, we're going to wind up now. And to everybody on the call, thank you very much for coming for Pain Forum. Keep your eye out for the next one. Follow us on the dreaded X or Twitter, or you'll receive a post-event email which has our education email on it. So if you want to rather be on it than on a mailing list, we can do it that way. But thank you again to Cass, and good evening to everybody. Oh, and good luck in the Scottish Parliament as well.
Thank you.
Okay. Thank you.
Bye.
All right. Bye, everybody.